It's a heavy afternoon. Thank you all for being here to go through pitfalls and challenges. So another case review, and there's going to be 10 cases, which means in half an hour, it's like 3 minutes a case. So it's a really busy breast MR reading day, okay? So let's just jump right in. And sometimes I'll poll, sometimes I won't. We'll see how it goes. So keep everybody awake and on their toes. This is a early post-gadolinium subtracted MIP, okay? So the overview, start off looking at background, then looking for things that stand out above background. I'm hoping that you all are now looking at the left breast, but in case postprandial narcolepsy is kicked in, that's the prior, that's the current, and there's a big orange arrow on this thing. So a little line going anterior posteriorly. Looks like it's new from prior. Here are some of the selected slices. I tried to match them up as much as possible, accounting for differences in positioning from year to year, but could not find it on the prior. So, BI-RADS assessment, as you all have learned, when there is something that rises above background, especially what looks like linear enhancement, it should be a BI-RADS 4 suspicious. So now this talk, when you all got comfortable with that concept, is to say also watch out for pitfalls. So apologies, but it's one of my pet peeves. So this is the current study, and this is a coronal and an axial matched set. And the reason I'm showing the coronal in this case is because you see that line, it actually goes kind of in a strange direct A to P direction, not truly following a ductal pattern towards the nipple. And then on the coronal, you'll see that it's actually a little bit wavy. So if you follow this anteriorly, it starts to curve medially, and then the bottom part here starts to curve laterally a little bit. Actually, I think that's a vessel, sorry. It kind of curves like this. So I'm going to lead you a little bit. Looking at this, notice how bright the skin is here. That's not pathology, that's just an artifact. It's really close to the coil, and for some reason, the medial coil elements are really making the medial aspects of the skin look super bright. So if you were to take this and imprint it over here, I'll tell you, trust me, it's a complete match. Okay? So this bright skin line is due to phase artifact. Remember, we run the phase in right to left because we don't want the heart phasing through the left breast. So we'd rather move our artifact right to left rather than anterior posteriorly. And so this is a mimic. This is not real enhancement. This is mimicking linear NME. So if you just looked at the MIP and tried to read it in 30 seconds, which I don't recommend, you'd go down the tubes, and then this would be a non-visualization at biopsy situation, right? So it's a pitfall, okay? So just watch out for those phase artifacts. Case 2, newly diagnosed cancer. You get the whole stack, give you time to digest. Ooh, yes. Okay. It's going to go again one more time. These are actually the hardest to read, I think. These take the longest. Give me a normal screener anytime, but then the newly diagnosed cancer, that's the one that kind of sits on that list. You're waiting like, okay, will the colleague take it first? Who's up next? But, just take it systematically. Take one breast at a time, one side at a time, start counting up dots. This is why it's so important to try to figure out what's background, and then you can think about what do you want to go after. Okay, so a lot going on. Just a show of hands so you get some physical activity. How many of you would recall something on the right or think there's something going on the right? Anybody? Probably everyone is too busy looking at the left, forgot about the right. Well, the left is the newly diagnosed cancer. There is a satellite lesion, which now I know I probably have to change that terminology the next time I do the case once new BI-RADS comes out. But there's a mass that is separate from the primary, but looks kind of like the primary. And then there was some right breast non-mass enhancement or background, depending on how you feel about it. I think this, in the new BI-RADS terminology, perhaps would be a small oval mass. Remember, we're not trying not to use focus. But in the setting of a new cancer, I tend to be a bit more conservative on the contralateral side, knowing that she has a left invasive ductal and likely a second site of disease within the ipsilateral breast. On the right, that clumped enhancement, I would call a 4. You can ask for that diagnostic mammogram if they haven't done that yet. Like even if they had a normal screener, sometimes it's worthwhile doing a diagnostic mammogram and perhaps a targeted ultrasound to see if you can find a correlate. In this case, mammogram did show suspicious calcifications in a similar, though smaller distribution. So that increases your concern even more. But now the question is, do you do the MR biopsy or the stereotactic biopsy? So this is a judgment, right? Depends on your practice, which one may be most available, and also how sure you are that the calcifications you're seeing at mammography also match up with the MR biopsy finding. So that's a separate issue. But in general, when you see something on the contralateral breast that could be cancers, it's important to make that diagnosis now. So that's not a time where I would use a probably benign wait 6 months, because management is happening now and it would be important to exclude cancer. Now, because the patient had a large primary tumor, she also underwent PET-CT scanning for looking for distant metastases. And unfortunately, the right breast was no longer the main issue. There is clearly a very large area of activity in the hip. On the left, here's the fused, showing you that it does indeed localize to her bone. So because of that abnormal uptake in the hip, a bone biopsy was performed instead, and now that it's positive for metastatic disease, that changes the treatment paradigm. So the patient received chemotherapy up front, also radiation to the hip, because we don't want a pathologic fracture, and also for symptomatic relief, and then hormonal treatment because it happened to be an ER/PR positive tumor. And then the patient actually underwent bilateral mastectomy, hysterectomy, and oophorectomy because this was a desire of the patient to actually transition from female to male. So I remember the patient actually talk about having a positive attitude, glasses half full. The patient said, I've been fighting insurance to try to get coverage for transgender transformation surgery. And guess what? At least in the state of California, once you have breast cancer, you can have all the reconstructive surgery you want in order to be whole. So that was the silver lining for this patient. Okay, case 3, high-risk screening. This is a subtraction. It's a sagittal reformat, and there is an obvious white spot there. Okay, so not an eye test. All right, let's poll the audience if we can. If you guys have a moment to get your phones ready. If not, it's okay. Just think to yourself, what's your BI-RADS assessment? I left the picture up so you can see. Yay. So you're supposed to say it's something suspicious because I'm showing you this solitary white spot on a completely black background. All right. Let me show you the axial. This is the same phase, and it's also a subtracted image. It's a T1 postGAD subtraction, and now hopefully you're noticing it's not the most beautiful MR subtraction. There's some artifact. See all the fuzzy lines here? It's not that crisp. So that's the area that I showed you on sagittal earlier, and now you see it in the axial plane. So this is where it is nice to look in multiple planes to determine what is the three-dimensional nature of this thing that I'm looking at. And also, for me, it helps a lot to troubleshoot artifacts and localize. So hopefully now you're kind of second-guessing that 4, BI-RADS 4 suspicious. You're like, boy, that's a really strange-looking cancer, right? It's kind of planar and very, very long and wrong direction. So hopefully now people would vote maybe benign or probably benign, or ask a friend. Anyway, this will, if I were to poll you, I hope we would get kind of a variation of responses. Let me just explain what's happening. So strange shape should always get you thinking, okay, could this be artifact? This is artifact due to misregistration, and the key is looking at the pectoral muscle. So those of you who've heard me speak on this before probably figured it out already, but that banana-shaped, crescent, boomerang-shaped thing, that's where the muscle lives, that is a classic look for pectoral muscle misregistration. And usually it happens not because the patient's literally shifting deep and superficial, it's because the muscle is tensing and relaxing, right? So she's twitching. And then between the pre and the post, the muscle has changed in configuration. And when the patient moves her pec, like if she tenses her pec, it also is going to shift the breast. Same thing would happen if she lifted her head up in MR. Like in MR biopsy, we really hate it when the patient does that because we tell her, if you lift your head up, you're going to move your breast. And we're looking for something small. And, we kind of have to double check and start over at that point. So let me show you, so this is misregistration artifact. Let me show you what it looks like non-subtracted. So there's the pre and the post. And the funny enhancing line you saw was this contour of the fat fibroglandular interface. Okay, so let me show you here. This is fat and fibroglandular tissue. And this is fat and fibroglandular tissue. But if the muscle is shifting in configuration, here it's more flat, and here it was a little thicker and pooching more, that's going to make the whole breast shift forward. So that's why you had that pseudo-enhancement or misregistration. If one were to draw a region of interest, little ROI right there, and right there, you would see that there isn't any major change in signal intensity. So that would also prove it to yourself. It's not enhancing. So you always go back to your, what I call the source images, the pre and the post contrast series. The subtraction, the MIPS, those are nice shortcuts to highlight abnormalities, but always verify on the source. Okay. Case 4. Sagittal plane, lots of abnormal enhancement. There we go. A lot going on. Maybe a little bit of normal tissue here, background. So I'm just illustrating extensive clumped enhancement, almost confluent enhancement. So whether you call this a mass or almost confluent non-mass enhancement, it doesn't really matter as long as you get to the right answer, which is this is AB, abnormal. So normal breast tissue there. Sometimes it's hard to find the normal breast tissue. There's the clumped non-mass. And hopefully as we sit here looking at these images, you will additionally pick up more findings. There is linear non-mass enhancement, sort of like 3 clumps in a row, extending towards nipple. This was all DCIS, believe it or not. Oops. I also show you, those of you who are paying attention, there is additionally this enhancement that goes up to the base of the nipple. Now, a lot of times you'll see T1 bright signal, so you're going to confirm that on your pre-contrast T1. But these are pertinent findings to alert the surgeon to, that the enhancement in this case, I would say, goes to the nipple base. It doesn't go into the nipple, but it does go to the nipple base. And so all of this was DCIS. We did this MR back in the old days, hoping or just making sure we don't miss invasive cancer. And so, a nice biopsy in the middle of this would be all you need to exclude or do your best at excluding invasive disease. Okay, case 5, newly diagnosed cancer. So this is that parade of complicated MRs, and you're thinking, where are the high-risk screeners? I want a screening case. Not the best positioned MR, but there you have it. So you just read it. Here it is, a couple more slices. Okay. So again, a lot going on. And you kind of just read through the positioning issues. So nothing, she's never had surgery, just the breasts were not positioned symmetrically. Okay, so right breast, left breast, neither or both. I'm going to go back through so you guys can think to yourself now that you know what the question is. It's the usual question. You're reading an MR and you're like, okay, is this BI-RADS 6 next case, or is there something else that I need to do? Is there unfinished business? So once again, going through, what do you do, right? I like the Brigham's call a friend or have a couple more people read out. We luckily, we're only a phone call away. We usually have more than one person on service. And these days, anyone can access the list from anywhere, so different campuses. So we'd message each other, hey, can I get a second opinion on such and such case? And sometimes you don't even tell them which side's abnormal, so you see if they all converge on the same thing. So that's the big question. And then the BI-RADS assessment, of course, will depend on whether you think one side is abnormal or not, if there's something in addition to the known malignancy. So since it's late afternoon and we all had lunch, I'm going to just show you the findings. So this is show and tell. There's a bunch of linear enhancement, non-mass enhancement on the right. There's also some similar appearing enhancement on the left. And then another area here on the right and the left. Now the left is starting to look more clumped. And then here even maybe some distortion. So the known invasive lobular was in the left. But the right and the left really look very similar to me on the MR, right? I'd be hard pressed to figure out which is which or even identify the primary. Sometimes I test myself that way. I don't immediately check where the primary is. I just look at it overall, try to look at it blinded and see if I can figure out what's what. And then, of course, I'll go back and find the clip, match it up, and look through all the prior imaging. So there's suspicious linear and clumped non-mass enhancement in the right outer central breast. At least that's what I thought. I called it BI-RADS 4 suspicious and recommended MR biopsy. Usually when it's really thin linear non-mass enhancement, I don't do breast ultrasound. I don't do targeted ultrasound, especially in a really large breast. This patient was pretty big. My concern is that I will be all over the place and I won't actually find the correlate. So MR biopsy, of course, I got atypical ductal hyperplasia, papilloma, and a radial scar. So the whole rat's nest of atypical lesions. So recommended excisional biopsy. I figured the patient's going to surgery anyway because we know there's a left invasive lobular and I can localize that clip and it can be excised and then we'll have more tissue and then we'll know. So what I didn't bank on was neoadjuvant chemo because the primary was greater than 3 centimeters. So this is where it can get a little bit more challenging. But you work with it. So luckily these days we also are doing more monitoring of high-risk lesions. Now note, this is all under supervision. So the patient's under the care of a surgeon and an oncologist. It's shared decision-making, but we also do radiologic pathologic correlation. And as a radiologist, it's my job to figure out, was this tip of the iceberg and do I think we need maybe additional biopsy even to prove or disprove cancer versus this is in the bucket of atypias that it confers higher risk and, just manage the known cancer. So in this case, in the bucket of atypias, lumpectomy was performed on the left. Path showed residual invasive lobular. We also did excise the right after chemo, and they found a focus of atypical ductal hyperplasia. So this patient is one of those that's going to be recommended for annual MRI surveillance because of the high risk and personal history and also the ADH. So sometimes it's not a perfect resolution to your biopsies, but just showing the challenges that we face. And again, working with the team to manage the patient safely. Okay, case 6, screening MR. Yay, screening, but troubleshooting needed. So there you go. What doesn't look good? Hopefully, you'll feel like, well, what are these? It's zebra stripes there, this rainbow. Yeah, did the phase get swapped? So I'll tell you, I was actually troubleshooting this over the phone in transit to a different campus. So this came from our county hospital. The radiologist, who has been ingrained in artifact troubleshooting by me, called me and said, "Hey, I think something's wrong. The fat set's not good, and then there's all these parallel lines, and it's curved, and it's going front to back." So I'm thinking, aha, the phase is going the wrong way. So I told the person, tell the technologist, ask them, which way is phase going? Is it right to left or front to back? And they said, oh, phase is going right to left. Like, really? And then, bear in mind, I hadn't seen these images. So they did it again. It's still the same outcome. So I thought, well, it really sounds like a phase swap artifact. So I thought, whatever is happening and whatever's going on with the controls, I know there's only two choices. So I said, whatever the tech is doing, just tell the tech to swap, right? So just swap it. So this is wrong phase direction. It's going anterior to posterior. So this is why we run phase right to left, or one of the reasons. This is the chest wall, or the back of the chest wall. The back of the thorax is phasing forward. And that's what's going on. And it's because it's dark back here. So you have the black stuff phasing forward. So the phase was changed to right to left, like it's supposed to be. And now, again, I'm troubleshooting all of this without seeing the images. I only saw these after the fact, but the radiologist did a great job describing. And so the description was, well, now the breasts are two different colors, but at least the phase artifact is gone. And I asked the key question, is the tissue black? Is there black breast tissue? And so that is the key in terms of answering, like, what's the problem now? So not phase artifact, we fixed that, not distortion. Poor fat saturation, yes. Significant water saturation, no. So it's just poor fat saturation. Well, just poor fat saturation. We don't love that either, but you live with it sometimes. So inhomogeneity of the fat saturation. The tissue itself, though, is okay. So it's gray, not black. You can read through this. The chest wall is another story, but luckily in this case, we can give that up. If it was a question of chest wall invasion, then obviously you'd have to fix it. But in this case, looks okay. So we let this go because at this point we'd already spent or wasted 15 minutes troubleshooting, and you want to get to the contrast so that the patient can have a diagnostic exam. So I learned a couple things. And subtraction can help bring out the enhancement. So a few things I learned through this process. Depending on your vendor or your manufacturer, we think in terms of which way is phase going, but the technologist may be selecting the frequency direction and not the phase direction. So for this vendor, the box is deciding which way frequency goes. So it was frequency going right to left. But when I asked, is phase going right to left, they didn't hear the phase. They just saw, oh yeah, it's right to left is checked. So just unchecking that, flipping it, made frequency go A to P, and now phase goes right to left. So the different vendors do it different ways. Just like the number line, like whether water is to the right or to the left of the fat peak, that is vendor specific. So that's why your techs have such a hard time, right? You just got to know. And I put up little cheat sheets, or used to, and now you can put in these programming notes and protocol notes for the technologists with little diagrams so that they can remember which way things go. So phase should be right to left for breast MR for these reasons. And then you want to make sure that you're not turning any tissue black, because that's a problem for interpretation. So in this case, the subtraction was great for bringing out the enhancement. Unfortunately, there was also a lot of background enhancement that had to be, looked at. But at the end of the day, at least it's a diagnostic study. All right, case 7. 43-year-old, personal history of breast cancer, had a right lumpectomy, had whole breast radiation, and now is on surveillance. So it's a screening MR. Here's the T1 fat suppressed after contrast. We see contrast in the heart. Not a whole lot going on in the breast. That's good. You can see the scar here from the lumpectomy. And then you look more closely and you see that, boy, it's really black there behind the nipple. Okay, so what is that? this stuff. This is just a photographic enlargement, so I just zoomed up the image so it would display. Okay, anybody know what this is? Or anyone use this at your institution? It's really, really black. It's actually a type of susceptibility. So when things go completely black and you didn't cause it, meaning you didn't create the water set, it's inherent. So any type of metal, any kind of ferromagnetic material will cause susceptibility. Just like your titanium clips, even though they're not ferromagnetic, they make a little tiny black hole. So here's the T1 non-fat sat that really brings it out. Now you see it a lot, right? There it is. So the cause in this case is a superparamagnetic iron oxide injection. And our surgeons are using this for sentinel lymph node biopsy. So instead of injecting radiotracer or methylene blue dye, they're injecting this slurry of iron oxides. And it's because they can use the same detector as they use for our localization. So we use something called a magseed. It's a little stainless steel bar that can be magnetized and it makes noise in the OR. And similarly, little tiny iron particles can be magnetized and they make noise. So they go to the axilla, and that's how the surgeon is identifying the sentinel nodes. Unfortunately, we learned the surgeon was injecting periareolar in the OR, or in periop prior to going to the OR. And this material kind of hangs out behind the nipple. It stays in the breast, and it creates this huge susceptibility artifact, which we were hoping would go away, but years later, it's still there. So this is actually in the literature now. We did write this up, and it's a pitfall. It's something to watch out for. So we only do this now in patients who are going to have a mastectomy. If they're going to have breast conservation, we have a different method of injecting. So we complained about this, and now all that did was buy us more work. So as radiologists now, we inject peritumorally this iron oxide particle before they go to the OR. So we localize them with the seed, and then we also inject the iron oxide particles around the tumor. So this is work in progress. We will have to wait for these patients to come back for their annual MRI before we'll know if it worked or not. But the idea is that the surgeon resects the injection tract as well as the tumor itself. So we'll let you know. Meanwhile, there are perfectly good ways to localize sentinel nodes, like I said, with radiotracer or methylene blue dye. Just so you can see what this looks like in the OR, this is actually a stained lymph node. This came from the vendor, and the injection is similar to a blue dye injection, like methylene blue. The iron deposits in the sentinel nodes, and it's detected with a magnetometer. It also has that nice feature that you can see it visually. So you see that it stains a dark color. So the question is, does subtraction fix this? Unfortunately, no. It's basically, it's a type of water saturation. So it's completely saturated out. You can't really see anything through it. Okay? So there's the subtraction if you weren't convinced. And the susceptibility artifact is still there. In fact, it's just way too clean and too black in that area. So just to show you again, there's an enhancing liver. That's black because of susceptibility from this patient's aortic stent graft. You cannot see any enhancement there. And it was still there 1 year later. Okay, case 8. I'm just going to show this to show the phenomenon. This is hopefully not a diagnostic dilemma, but there's a mass, there's the pre, and it's really, really bright. Patients had a lumpectomy for cancer. This is a postoperative seroma. So not a diagnostic pitfall, but sometimes I'm asked, like, why is it so bright on the pre, right? Looks less bright on the post. It's because of the gadolinium that comes on board later. So it's just relative signal intensities. On CT, you have a defined scale. 0 is water, minus 1,000 is air, etc. MR, everything is relative. There's no set scale. So it changes every time you retune the magnet. So whenever you do a pre and then you do the post, you give a bunch of GAD, it changes the scale. Because gadolinium is super bright. So that's going to need some of those signal intensities. So I'll just show this in a visual. Let me show this diagram. Say on the pre-contrast, this is the range of intensities there, because there's no GAD on board. That gets mapped to your grayscale display. Okay, you have 256 colors, say. Well, there's your pre. Now, after you give GAD, the signal intensity range is huge because gadolinium, So there's your grayscale display. And again, relative signal intensities on MR, pre, things are often brighter. Post, it looks darker. Don't stress about that. It's just the relative signal intensities. Okay? So that's just little MR physics. Okay, I'm going to end on this case 9. Patient with a newly diagnosed tubular carcinoma, T1 fat sat with contrast. This is just a show and tell. Again, look at the mediastinum. There's some extra dots there, or extra blobs. So mediastinum is abnormal. There are lymph nodes there that are enlarged. So we did a PET CT. Remember, tubular carcinoma is a very low-grade tumor, not supposed to have malignant, like metastatic nodes in the mediastinum. But that will cause it. So patient had a primary lung cancer. So sometimes as a breast imager, we look a little bit beyond the breast to do good. Okay, so I'm going to end there, and thank you so much for your attention.